I'd like to show you how to examine the lower lumbar spine and thoracic spine. Okay, would you like to walk towards the computer and back towards me again, please? So, looking at someone's gait, obviously this can be assessed when they come into the actual examination room, but it's a very good assessment of the neurological function of the legs. They've got to be working really quite well to be able to walk normally without any evidence of an antalgic gait. Clearly, if someone comes in their wheelchair, that says a lot about the patient, and if they do that, you must establish if they can or cannot walk. Okay, so while they're on their feet, this is an opportunity to assess their plantar flexion and dorsiflexion of their ankles. The plantar flexions of the ankles are very strong muscles, and it's quite hard to assess them properly whilst they're lying on their couch. So, I just steady the patient in case they are feeling unsteady, particularly in the elderly. Could you just go onto your tiptoes for me, please? And the demonstration of plantar flexion very nicely, and then onto your heels. So we're demonstrating dorsiflexion of the ankles here. Again, they can be very unsteady here, so make sure you don't drop them. Okay, just turn around so I can have a look at your back. During the history, you need to establish where the pain's coming from, but I think it's very important to ask the patient to point exactly where the pain's coming from whilst you're looking at their back. This is very hard to demonstrate this while you're taking the examination. You lower the trousers down ideally, and you just point exactly where the pain's coming from, please. Just there, okay. It's very important to differentiate between buttock and lower back pain. People often feel that's the back, but that could suggest evidence of nerve root impingement and can mean a completely different set of pathology. Whilst looking at the back, we're looking for the natural contours of the spine, both from the back and the side. So from the back, we're looking for evidence of scoliosis. We're also looking at the skin, looking for any abnormal patches of hair or cafe au lait patches. And from the side, we're looking for the normal lumbar lordosis and the thoracic kyphosis, looking for a nice smooth curve. Then we go on to palpation. I generally focus on where the area of the pain is. So it is that sore? No. Often the actual pain cannot be reproduced by palpation, which can suggest referred pain or quite deep-seated pain. No problem at all. Okay. Now we'll assess movement. So just don't hurt yourself, but just bend as much as you comfortably can down towards your toes. So here we're looking at the amount of movement getting the hands down towards the feet, and we're looking to see if it's the hips or the actual spine that's moving most. And up you come again, and then bend down again. And from the back, we're looking for any potential rib hump to suggest a scoliosis that can't be seen by simple observation. And then we look at lateral bending. Just come like this to the camera. Just slide your right hand down your thigh as far as you can go. So we're looking for a nice smooth curve to the right and to the left. And up you come again. Obviously evidence of muscle spasm will be picked up at this stage if it's dynamic. And don't move your feet, and just let me twist your spine. This is mainly thoracic movement, rotation. Again, looking for any evidence of pain. If you demonstrate pain, make sure you know exactly where it's coming from and if it goes down the legs. Any problems at all? Nope. And just arch back for me, please. Make sure you steady the patient so they don't fall over at this stage. Up you come again. And pain here can demonstrate facet joint impingement or possible radicular pain by compressing the posterior elements. Okay, would you like to lie on the couch for me, please? So now we assess the neurology of the legs. We're really just trying to find out if there's any nerve involvement as the nerves run through the spine. Can you feel me touch you here?
Yes.
Does it feel normal?
Yes.
Same both sides?
Yes.
So we run through the dermatomal distributions here. Feel me touch you here?
Yes.
Normal, same both sides?
Yes.
And here?
Yes.
And here?
Yes.
Normal, same both sides?
Yes.
And here?
Yes.
Normal, same both sides?
Yes.
And here?
Yes.
Okay. Now we go on to power while I'm down here. Can you pull your toes up, George? And hold them there. Pull, pull, pull. Okay. And now push me away as hard as you can. Push, push, push. Good. Well done. Just lift this knee up as hard as you can. Okay. And this one. Okay. Just hold your leg. Don't let me bend your knee. Okay. And now bend your knee. Good. And don't let me bend your knee. And now pull it in. Good. Okay, that's power. Now we go on to reflexes. Just try and relax as much as you can. Okay. So this is the knee jerk. Okay, then we go on to the ankle jerk. So we're feeling the foot and also looking at the calf, looking for the contraction. Okay, and then we go into plantar reflexes. Now I normally go into the straight leg raise, which is a provocative test. Here you're pulling on the nerves that run down the leg, and if they are being trapped in the spine, this will exacerbate the patient's symptoms. So passively, lifting underneath the foot, look at the patient's face. Tell me when to stop. Okay.
Okay.
Okay, what's happening there?
It's tight in the hamstrings.
Just tightness, no pain.
Yes.
Okay, and then down we go again. And tell me when to stop here.
Okay.
What's happening there?
It's tight in the hamstring again.
Same as that side.
Same as the
Okay.
side.
So that was a negative SLR. A positive SLR would be actual pain going down the leg, which can come on as early as 10 degrees. Now I'd like to test the vascular supply to the feet. This is really for patients who've got signs of claudication to differentiate between vascular and spinal claudication. If they're good pulses in the feet, it pretty much excludes any chance of vascular claudication. Then I'd like to examine the hips. Again, there's a lot of overlap between hip pain and spinal pain, and if they have a good range of movement in the hips, just bring your hip up and just, any problems there at all?
Nope.
So the movement I go for is internal rotation. That's the first movement that tends to get restricted and tends to cause pain with osteoarthritis of the hip. And if that's full and pain-free, I assume that there's no real problems with the hips. Problem?
No.
Okay. I don't normally routinely do a PR examination, but in the history, if I pick up any evidence of any red flag signs, I'll go ahead and do this now. If from the history you pick up any red flag signs, it is important to do a PR examination. Clearly this is a much more personal examination than what you've been seeing, and you must obtain a consent and, if appropriate, have a chaperone. I feel there are 4 important points to demonstrate during this. One is the actual appearance of the anus. If it's patulous and looks relaxed, that is a sign of abnormality. The second point is when you actually have your finger inside the patient's anus, if they can actually demonstrate any anal tone. A completely relaxed anus, there'll be no tone whatsoever, and it's quite a striking difference when you do palpate it. Thirdly is if the patient can actually voluntarily contract down onto your finger. And fourthly is if the patient can actually feel the finger inside. As you're doing this, it's important to test perianal sensation as well, both to the left and the right of the anus. Any abnormalities really do indicate that an urgent MRI scan must be acquired straight away. Thank you. So that was the basic examination of the lumbar spine and thoracic spine. I'd like to talk about some additions you can do to that examination. First is the Schober's test. It really is to pick up how much flexion there is in the lumbar spine. Just face away from me, please. So we have a tape measure, and it can be 10 or 15 centimetres over the lumbar spine, ideally starting at the base of the lumbar spine, and then you ask the patient to bend as far forward as he comfortably can, and you're measuring how much it moves, and up you come again, from the 10 centimetres, which I've done it, and it went up to 17. Okay. The next sign is the, if you just face the camera, is the Faber test. I believe that was done during the hip examination, and I won't add to it from what was being mentioned already. I'd like to go on to some provocative tests now. If you just lie on your back on the couch, please. During the basic examination, I talked about the SLR, which really, as I said before, is just stretching the nerves down the back of the thigh. There's some modifications to that and additions, something called the Lesage sign. So just as before, we lift the leg up, looking at the patient's face, making sure we're not causing him any pain. And for instance, if you had a positive sign here, you can get the foot and actually dorsiflex it, looking at the patient, and see if that worsens the symptoms, and that would suggest nerve root tension. Then you can relax the knee to 15 degrees, which should greatly relieve the symptoms going down the leg. And there's the possibility to actually do the bowstring test, where you forcibly push onto the nerves in the popliteal fossa. The other test is the femoral stretch test. This really only needs to be done if they've got pain in and around the thigh and knee, to see if there's any evidence of femoral nerve impingement. Just roll onto your tummy for me, please. So here you're stretching the femoral nerve, and a positive sign will be pain in the actual thigh. So whilst looking at the patient's face, you bend the left knee. Any problems at all?
No.
I feel it's excessive to actually extend the hip. I find just flexing the knee and looking at the patient's face, and if you can go up to about 45 degrees without any problem, then that's fine. This one. Any problems?
No.
Good. Okay, up you come. Well done. Again, it's important to state that an MRI scan is a wonderful investigation, and often you can be causing excessive pain to your patients trying to elicit some of these signs when it's all clearly seen on the scan. One of the problems with the back is that the examination actually takes quite a long time. It can be pared down to the minimum. I'd like to demonstrate a 1-minute examination of the lumbar spine. You just walk towards the computer and back towards me again. So again, we're looking at the patient. We're getting a good assessment of the neurological control of the legs whilst she's walking. And stay there. I think it's very important to demonstrate where the pain is, so quickly get the patient to demonstrate where the actual pain is, if it's buttock or lower lumbar spine. And can you just go off onto your tiptoes for me? And then onto your heels. Okay, and just bend as far forwards as you can. And up you come again. Okay, thank you. And I feel those are the most important parts. You've assessed the neurological control in the legs, you've assessed movement, you've assessed how painful the spine is with the patient moving. If you do pick up red flag signs in the examination, I think you're obliged to do a PR examination.